I think, it's all here, Elaine.
Elaine,
Kate.
Nancy, and Kate.
Yeah, so I mean, we've all taken care of these patients. I think you're all familiar with these patients.
See the screen, because I can't see. Can't see the big screen. I lost my glasses.
Oh, no. Oh, no. Okay, they'll change after.
Right.
Anyways, so.
Exactly. Okay,
So I think a lot of this is gonna be just a refresher. Kate, obviously you're on the newer side, but I know you've taken these patients and you ask questions when you need to. So,
we're gonna skip the first couple stuff because it has to do a lot with like pre-op stuff, and we're gonna talk about like post-op day one and on. So we didn't make a new presentation. We're just gonna kind of talk about the things that are pertinent. So if you
Um,
see us skipping,
actually, since they're all ICU, we
Yeah.
can do like pre-op orders.
Okay. we'll talk about that.
Just, yeah, we can. So if
Okay.
you're taking care of these patients prior to surgery the next day, some of the testing that we need them to do, obviously, if it's emergent, it's going to be different. But if this is a planned, they're gonna go through a carotid ultrasound, they're gonna do an echo. We're gonna do labs prior to them going in, the earlier the better, so if you can do them at like 3 or 4 o'clock in the morning, just so we have them. They should order a UA, a MRSA, a type and screen. Once again, if this is planned, Erica has already got these done. Respiratory, they should have done outpatient, a PFT. For us, on our Mars, we'll see that they're gonna have aspirin 81 milligrams and their beta blocker. We wanna make sure, unless there's some contraindication, we make sure they give them the beta blocker. And that beta blocker is made to help them prevent AFib, because a lot of these patients will go into AFib. If it's a valve, it's gonna be more prominent, but generally think of rule of thumb, 30% to 50% of them are going to go into AFib. And we've tried to solve this problem multiple times by giving them amiodarone during the procedure, amiodarone when they get out of the procedure. And we have a very high incidence in this area with these patients going into AFib. And when they go into AFib, then their stay is generally going to be longer. And talking to a multitude of surgeons that we have had through here in the last couple of years, we have the highest incidence of AFib. And I think it's literally just a healthcare problem with these patients not seeing a doctor ever, or just not being, they're not reliable in getting healthcare, as opposed to Good Shepherd, where, you know, the clientele is much different.
Thank you. Thanks.
They match my shirt.
How they do? If you guys could see Amanda's nails right now, they match her shirt. They're sparkly. So order sets, now that Erica's back, she will put in her order set. She's constantly revamping it, but it's pretty much, if you've ever seen Elijah's with AIP, it's his, and she's just kind of gone off that. Every person is going to have 4-pack cells on hand and 2 platelets. Platelets, as we know, are on short supply here, so if they need more platelets, it's not gonna always be guaranteed. So if the surgeon asks for more to us, then we need to tell them that they may not get it. And this has been an issue with recent ECMOs when they're going back and they're bleeding a lot. We've held 6 for them, and when the time came, they got 2, and it's a giant issue. No Plavix, Coumadin, no blood thinners, 5 days prior surgery. Obviously, if it's emergent, then we're gonna reverse it. And then Lovenox for any surgery, DC 24 hours ahead of time. And then if they're on a heparin drip, we're gonna usually stop it at about 3 o'clock in the morning, and they should put a time in there that they want it. If not, ask who's ever charged and see what time the case is. So our teaching for the patients, I'm not sure if there used to be a channel, I want to say it was like 55 on the TV that had, no, that used to have the teaching on there that we could turn on.
That's nice.
Surgery is about 4 to 6 hours. They're gonna wake up, everything that you tell them, they're gonna forget. So, the vent weaning process, all of that stuff. Biggest thing is, once we get them extubated, they're gonna have pain. No matter how much pain we tell them they're going to be in, it's not gonna be the equivalent of what they're actually going to feel. If that makes sense. Obviously, women, I have found, tolerate the surgery much better than men, especially middle-aged men.
Mhm.
Yeah. So, expectations, as you all know, they're gonna ambulate 4 times a day. Coughing and deep breathing is the biggest thing. It's the biggest thing I think that we lack on, because we're not in the patient's room with them every second. And in order to get out of here, in order to prevent atelectasis pneumonia, they need to cough, they need to deep breathe. Unfortunately, those are the two things that hurt the most. And walking. They're gonna be up to the chair for every meal. And then, depending on what day of the week it is, participate in PTOT, because sometimes PTOT comes, sometimes they don't. And we've had issues with it in the past. I know it's gotten better recently because Erica has talked to PT, but it's been pretty much the answer that I was told when I inquired about it was they don't make money off of going in there and helping these patients, which is sad. Average day, our goal is 5 to 7. The fastest I've ever seen is 4 days. And as you know, we've had people in there for 3, 4 weeks because they develop pneumonia or they're just not moving, they're not compliant, they go into AFib. They go back, they have another cardiac arrest, they tamponade, stuff like that. But our goal is 5 to 7 days. So what is a CABG, a coronary artery bypass graft? I'm sure you all know this. What we're doing is we're creating conduits around blockages. So we're taking arteries from inside the heart or our radial artery, and we're bypassing that blockage. We're also using saphenous vein grafts, which are from the legs, but not as reliable. The left internal mammary artery, that is part of their metrics for surgery. If they don't use that artery, then they have to state why. Is it diseased? Is it just not good? But that is the gold standard. The lifespan of that is 20 years or greater, as opposed to a saphenous vein graft, which is 10 years or greater.
Are you guys seeing the slides change?
Yeah,
Okay,
Yes.
thanks.
So we all know where the saphenous vein grafts are. As you can see there, like I said, the lifespan is about 10 years. So the medication that we give these patients, we've all given them. Antiplatelet medications, our most common is going to be aspirin. We give our beta blockers and then our statins. So pretty much we're giving them all at 9 o'clock at night. The aspirin, we are not. If you ever see aspirin or heparin on these patients, before surgery, if they're not on a drip or whatever like that, just inquire if they want you to give the sub-Q dose or the heparin dose prior to the surgery. Normally they do. They don't have an issue with it versus Lovenox. And then obviously for us being night shift, we don't have to worry about discharging these patients. So, but we need to ask if they're not going home on these medications, why they aren't going home on these medications. So as we talk to antiplatelets, so prevent blood clots, our beta blockers, mainly we're using these to slow down the heart. And that is going to be mainly to prevent AFib. And then our statins, they're going to be on for the rest of their life. Touch on this or?
Sure, we can talk about the valves. So aside from having a cabbage, the other type of procedure they can have is working out in the valve. And there's multiple different procedures that they can have to have that done. So depends on if it is either stenosed or has regurg. So stenosis is narrowing of the valve that impedes forward flow, and regurg is when blood flow starts to move backwards. So they kind of have to figure out what the problem is to know what kind of procedure they're gonna have to have that fixed. So a repair preserves heart function, and the perk to that is that they won't have to have lifelong coagulation replacement. It can be mechanical or prosthesis, and they need coagulation with Coumadin for 3 months for the other one. So the issue that we see a lot with valves are rhythm changes, because the aortic valve sits pretty close to the AV node. That's why these patients come out with wires, and we keep a really close eye on if they go into any blocks or anything like that. It's more common for them to go into complete heart block and need a permanent pacemaker, junctional, those sorts of things. And you can see on the picture kind of why that happens, because everything is so close together. A maze is a treatment for AFib. Usually they do this on top of another procedure that they're, already going in there for. So they ideally try and burn the places off that are creating the AFib to create scarring. You're not going to see an immediate resolution of the AFib. It can take up to a couple months for that to kind of stop and all this to take effect. So if your patient had a maze and you see post-op day 3, they go back into AFib, that's an expected finding, although we should still let somebody know it's expected. And then oftentimes while they're in there too, you can see on the right hand side of the screen, they'll clip off the appendage that can be causing AFib as well. There's another picture of it.
It's actually me cooking some short ribs.
Okay, we're not gonna go
You didn't
through
bring
these.
any?
These are old. And they're kind of more with like post-op day 0. Yes, skip to. Okay. So the most common complications, I'm sure all of us kind of know and keep an eye out for, but bleeding, tamponade, AFib, which we already kind of talked about. The stuff we see most often is electrolyte abnormalities, which is why it's super important for us to stay on top of that and check those multiple times a shift. Fluid overload, you'll often see these patients on all sorts of diuretics, respiratory problems, either from the above or from atelectasis, pain, etc., and renal issues and neuro deficits, which isn't as common.
Just to touch on, so electrolyte abnormalities. So CB is one set of surgeons that they want us to be proactive. And the order sets are already in there for all the electrolytes. If you think that you need to draw labs on this patient, you don't need to ask AIP. Just drop orders underneath whoever it is, if it's Beckett, and check that. We don't need to go to AIP to say, hey, can we draw these electrolytes? They expect us to do it. They sign the orders. I know AIP had a meeting not that long ago, and there's been some issues on what they'll order, what they won't order. But if you need electrolytes and a plate replacements, the order sets in there. Just draw the labs and be proactive
Mhm.
on it rather than bothering AIP with something like that. They're very easygoing when it comes to that because we've seen so many patients where electrolytes aren't drawn and we start having rhythm changes and next thing you know, they're, arresting.
Mhm. Bleeding, this usually happens in the immediate post-op period, but it can happen, a couple days later as well. Um, First you kind of have to find out what the issue is. Is it a surgical problem where something needs to be fixed? Or is it a coagulopathy issue where we just have to fix that and then the bleeding stops? And again, that more or less happens in the immediate post-op period, but it can happen in the later time too. Um, Obviously the solution to a surgical issue is going back to the OR, and there's a multitude of things that can go wrong that, ooze and bleed that need to be fixed, that can only be fixed in the OR, which are listed here. And then the coagulopathies, that's another thing that when you're in the immediate post-op period can kind of check on all of that and adjust those things, give product, etc., to reverse that. Tamponade, most common in the first 24 to 48 hours post. So this is definitely something that can happen on post-op day 1. It's where the sac around the heart fills with blood, which is causing compression of the heart and not allowing any sort of outward flow. Immediate things that you will see are JVD, narrow pulse pressure, lower blood pressure, or distant heart sounds. It can happen if the chest tubes become clogged with a clot or after pacer wires are taken out. Lelaine, do you have a question?
Yeah, regarding the bleeding,
Yes.
signs of symptoms like of course, seeing it on the incision site and then chest tube drainage. Is there any other signs that we should look for? Blood pressure, what else?
Yes. So you'll see a lower blood pressure, you'll see tachycardia, the increase in chest tube output. You might see if they still have a swan and you might see that their mixed starts to trend down. You will see cardiac output trend down.
Once again, look at your patient and see, I mean, don't fixate on one number.
Right.
Yeah.
But I mean, your patient's gonna look like they're going into shock and even not, this could be post-op day 1
Mhm.
and, just honestly look at your patient and, just be adamant. If you think your patient's bleeding, there's a good chance that your patient is probably bleeding.
Mhm.
And
Okay.
the more that you relay to AIP, the more that you relay to the surgeon, the better. Paint a very grim outlook because we had a patient recently bleeding. And I mean, it was abundantly clear that they were bleeding. Indexes were low, blood pressures were low. We were giving blood products. And it Chris did an excellent job painting a picture. Chelsea was in the room. I was in the room. And I mean, Helen Keller could have been in the room and noticed that this patient was bleeding
Okay.
and they still weren't coming in. And the down part is that the patient went back for 2 more surgeries the next day. Even though we painted a very grim picture. So. Good question, Carol?
No.
Oh, you're yawning?
Thank you.
You're welcome.
Mhm.
The good thing about these open heart patients is if they still have all of their lines in, you have all of that information, where
Mhm.
on a normal ICU patient, all we have is, a non-invasive blood pressure. But we can still look at this patient and say, they don't look good. They're cool, they're clammy. Their urine output has dropped. You know,
Mhm.
now with having a Swan, like Amanda said, now, you know, if that happens, once again, you know, draw an ABG. Draw a mixed Venus. Don't always believe that hemisphere is correct. We check them one time in 24 hours, which I think is not enough, but a mixed Venus is gonna tell you everything that you need to know and how well your body is oxygenating.
And be mindful to look at all the conditional orders. You'll find lots of things in there that you can use, and you don't need a provider's permission to do that. You can get a chest X-ray, you can get labs, you can get a CBC, coags, all those things. You can release just if you have a hunch that things aren't going right, and that's just fine.
Right, as Amanda said, if you think your patient's bleeding, you know, go in there, you put in an X-ray, drop an X-ray. Labs, fibrinogen, PT-INR, all of that stuff is in there, which isn't on every other ICU patient.
Mhm.
So you have everything that you need. If you get an ABG and your ionized calcium is less than 1.08, we can give calcium to them. Calcium has clotting factors in it. It's get AIP to the bedside, make sure that they come. And yeah, whatever you put in, they're going to sign. They're very good about that. They
Mhm.
expect us to do that.
Yeah. Cardiac tamponade, what do you do about it? So obviously we're gonna have to drain that blood around the heart so that the heart can continue to pump effectively, because with all that blood trapped around it, there's no squeeze or outward flow. They are gonna want to go to the OR to find source of bleed, essentially drain the blood out. If it's emergent enough, we can do a bedside sternotomy or chest tube insertion. So what can we do is, uh, nurses, we can apply some oxygen. You're gonna want to give these patients lots of volume because they're preload dependent. Whether that's crystalloid or blood or either of those things are appropriate. And then support them in the meantime with medications to improve cardiac output. Again, you're not going to solve the problem with meds or anything, but it can at least buy you time until they can have a procedure done to fix
And
the issue.
if you need the bedside sternotomy kit, it's when you walk in to the back room by 11. If you make an immediate left and above like all the arterial line stuff, there's a steel case that's on the top that says it on there.
Mhm.
Normally, we have two. There used to be one in Erica's office and then one there because 9 times out of 10, when you're opening it, it's a sterile case and we touch it. And now it's no longer sterile, so we like to have two cases there in turn, but right now we only have one.
AFib, which is probably the most common thing you'll see, especially on post-op day one. Happens a lot due to irritation or swelling of the heart. Like Joe said, we give beta blockers beforehand to try and combat this. It can also happen due to electrolytes being out of whack, which again is why it's so important to continue to monitor these and replace per the orders. The goal is to convert the patient back to sinus with amiodarone, hopefully. So obviously, everyone here knows if you get Lasix or Bumex, you're gonna see a change in your electrolytes, but that's why it's so important that we need to be proactive in checking all these things. It is not unusual to find somebody who is on 3 times a day IV Lasix and their electrolytes haven't been checked since 4 a.m. So again, you don't need permission to check that. That's just something we as nurses can put in and check. And that's something also to bring up during rounds to see if we can get stuff scheduled. But if I have a patient and I come in for my shift, I usually check and see when the last one was drawn, and if it hasn't been within the last like 4 hours, I just draw it and check. And the thing about the cabbage order set is that you're not gonna get the notification that prompts you to replace your K in your mag. You're gonna have to go look for what your K in your mag is and follow the protocol and put in the order. And if you guys aren't sure on how to do that, please grab a CV nurse or a charge nurse and we can help you on how to do that. Another very common complication is fluid overload, which happens a lot from all the fluid that shifts between the vascular space and interstitial space. These patients receive a ton of fluid during the procedure and the immediate post-op period, so they're usually pretty up on their weight, and then we, give them all the stuff to help them pee it out. So why it's super important to be mindful about everyday weights and I's and O's and stuff like that, so we can catch this kind of stuff before it turns into a problem.
One thing about diuretics, so if we need diuretics, don't ask AIP, don't ask primary, ask CV, even if they're an overflow patient. If they're just not peeing and you think you need something, send them a perfect serve message and they will generally order it for you. They like to monitor, even don't call cardiology either. They like to monitor their diuretics and what they're giving. They frown upon other people ordering them. If you can't get a hold of them and they're not calling you back, then go to AIP if they're not an overflow, but just be mindful of that. They're fine with 30 cc's an hour. Because, and if it drops below that and their creatinine is not getting any worse, they're generally fine. So if you do call and ask for 20 of Lasix and they don't give it to you, it's generally why, but just be mindful that we got to get these people to pee. We got to get them back to their goal weight, which is what they came in at. So.
On the same token as all this is respiratory problems, which again can either happen from pneumonia, atelectasis, or overload. So that's why it's so important for one, pain control, education with cough and deep breathing, IS, all of that good stuff. Yeah, I think that's it. Renal failure, again, is another very common complication, again, from all the fluid that we give and then the meds that we give to kind of pull it all off, and then hypotension in the immediate post-op period, and then being on pump for an extended amount of time. All those things put you at a higher risk of this. So we want to optimize their fluid status again. So that's another reason why it's so important. We are very up to date on the I's and O's every hour. Be mindful about using diuretics, not overdoing, to avoid further renal injury. Neuro deficits can happen, as soon as a patient comes back from the OR, excuse me. It can either be caused by a stroke, or from being on pump for an extended amount of time, which we call pump head. If you suspect a stroke, this is something we need to notify AIP and CV about. But again, like, that's usually something that happens as soon as we wean somebody off the vent. But if something happens more acutely, that's something where you need a provider to the bedside.
So if you think that the patient's having a stroke and they need a CT, so notifies CV, they get knocked if they are taken to a CT afterwards, because that's obviously, you're suspecting something's wrong. CV has to order the CT. AIP cannot, and AIP knows that, and Obviously, they'll be in communication with them. Sometimes they want you to hold off just to see if this, like Amanda said, is this pump head? Is this something else? But if you do suspect something, you need to get the order from CB to take them for scan, any scan.
Post-op standards of care. So this should be something that's kind of ingrained in all of our brains, because I know all of us have at least taken care of a open heart overflow. So they need to be in the chair for all meals. Their legs need to be up while in the chair with their TED hose on. They need to walk 4 times a day. IS at the bedside, cough and deep breathe. And when I say at the bedside, don't have it in the closet and the patient on the other side of the room. Please have it on their table so that they can reach it.
At least stage it so it looks good.
Right, at least make it look like they're trying. You want to get a standing weight. Of course, most of the time we're able to do that, but you know, there's sometimes patients are still bed bound or what have you. So just make sure they get a weight before they eat breakfast. Chest tube output is something that needs to be monitored, and urinary output as well. And all those need to be charted in a timely manner. You know, these aren't the types of patients where you can wait 5 or 6 hours and then go back and chart all that stuff. It needs to be pretty up to date. So in the case of an emergency or, you know, something happens, that all that's in the chart and the providers can kind of get a real-time picture on what's been happening. We need to do chest tube site care every day, cleanse with ChloraPrep and the gauze changed. Incisions open to air. If they are still draining, you can put the dressing on. Wean oxygen as best you can. You want them on the least amount possible. And of course, the TED hose off during time of sleep. Discharge, which none of us ever do.
So one thing to explain to these people, and we explained to them prior to surgery, no driving for 4 weeks from the surgery. That includes sitting in the front seat. The reason for that is because if an airbag goes off and hits them in the chest, then we're gonna have some issues. So they need to have somebody drive them around for 4 weeks. They need to sit in the back. No pushing, pulling. I think we all ingrain that in their head when we're getting them up every morning. No lifting anything heavier than 10 pounds. Generally, I tell them like a gallon of milk is the most that you should be lifting. No grocery bags, golf clubs. They shouldn't be golfing anyway. Don't lift your grandkids. Pretty much as an excuse to not do anything around the house.
Is that what you say?
So I say, that's why I want this surgery.
Yes.
So I don't have to mow, I don't have to pick up my grandkids, which I don't have. I don't have to take the garbage out, which my kids complained about last night. Yeah. Walk as much as tolerated. They're gonna be going to rehab either from home or they're gonna be in a facility. So they're going to be walking. It's okay to walk upstairs if they have stairs. Generally, we ask them how many stairs they have. PTOT should come in, and by the time that they leave, usually the day before they're leaving, they'll do stairs with them just to make sure that they can get up a flight and down a flight. Keep the legs elevated to keep swelling out of the legs. Continue the breathing exercises at home, which I'm sure 100% of them do not do. And follow-up appointment in 2 weeks with a wound check and suture removal. That should be scheduled by Erica prior to them leaving. Once again, all of us, we don't discharge, so usually day shift will make sure that that is set up for them. As Amanda already talked about, electrolyte replacements, that's just our standard of care afterwards. Calibrate the hemisphere if they have a swan in. Every day, we do it in the morning. And honestly, anytime we make a change in their treatment, we should be recalibrating it if they have a swan. So if we're turning off an inotrope such as dobutamine. An hour later, we should be checking a mixed venous to make sure that they're not going backwards, because those hemispheres are only as reliable as the number that you put in there, and over 24 hours, it's gonna change. If we're pacing them and all of a sudden they regain their heart rate back, then an hour after that, we also need to check. We just want to make sure that they're not going backwards, because if they go backwards, then they're going to be there much longer. And I can't even count how many times surgeons have walked in and said, oh, look at that, their index is, 3. But it says their mixed venous is, 40. Like, those two just don't calibrate together. So it's better just to have updated numbers, even if you want to come in on your shift and if they have a swan, draw a mixed venous, see where you're at, just so you have a starting point. Obviously we don't have showers, but when they go home, they can shower daily. Wash their incisions with soap and water. Don't put anything on any of the incisions, no antibiotic ointments, no lotions, no creams. Those incisions will fade over time. If it's draining, cover with a dry dressing. If it becomes soiled, just as if they're in the unit and it becomes soiled, change it. We don't use wound vacs anymore unless they're coming back and they're open, so we don't have to worry about that. So chest tube management. So normally we have 2 chest tubes that come in and they Y site into the Pleurovac. The one on the left will be, on the patient's left will be their pleural, and the one on the right will be their mediastinal. Always check an x-ray, make sure that there's no issue, especially if you're not getting a decent amount of drainage out of it. The chest tube on the left, the pleural, is usually the one that affects males the most, middle-aged males. When it comes into the body, it makes a slight right angle and it hits the nerves underneath there. And so these patients will generally complain of pain at the insertion sites on the left flank or mid to low back. Sometimes them turning in bed can make it better, but can also make it worse. Getting up and walking sometimes is challenging for these people, especially with taking a deep breath. Sometimes we have to pull the chest tubes early so that they can actually move and breathe and function. It happens very rarely, but this is where pain control is detrimental, because we need them to bleed, or to breathe, not bleed. Color of your drainage. So when they come out, obviously they're going to be bloody. That should clear up throughout your shift. By the time you guys get them, it should be serosanguinous. And then the amount of drainage. So as the days go on, this can change. Especially if we're diuresing them. Some people diurese out of their chest tubes, so it's pulling all that third spacing fluid out. And sometimes, if they're tamponading, they may not have any drainage or very, very minimal drainage. Always make sure to check the site right at where the patient is, because that's the first place we're going to see clots. So if you do see clots in there, break it up with your fingers, just kind of squeeze the tube. Obviously, don't pinch it too long. Don't strip the tubes unless we absolutely need to, but that's only in a emergency situation. So removal, we don't do a lot on night shifts. Sometimes we do, sometimes we have to do it just so these patients can function. CV requires 2 RNs, one to hold the site and the other one to pull. We need a suture removal kit, a ChloraPrep, some gauze, some tape, an underpad, a red bag to put the Pleurovac in the tubing, and then I always gown up because when you pull, clots can go flying. Let's go to the next one. So explain the procedure to the patient. Generally about 30 minutes prior to pulling them, I will give them some pain medication. I tell them the pain generally lasts like 1/10 of a second, and the relief that they get afterwards is going to be tremendous. So we're going to remove the dressing, cleanse the actual sites, I will generally kind of move the chest tubes back and forth, up and down, because over time, the blood kind of crusts on the inside. And if you pull them and it gets stuck, they're gonna remember that, and so are you. There's a knot on the sutures, if you guys haven't seen it, we just cut that knot and then unwrap the sutures. And these are called purse string sutures. So that when we untie them, you'll have two pieces. And then when we pull them, when we tie, we just tie knots. We leave generally about an inch. So that when they come back in to the office, that they have something to grab onto to cut the sutures from.
When you're pulling out the tubes, there's still the sutures left in, and that's what you tie.
So they have them wrapped around. I don't have a pen on me, but they have them wrapped around. Then you'll see where the knot is. You just cut on one side of the knot
Then you'll get
and then
two ends.
you'll unravel
And
them.
it'll be like really long,
Right.
Okay.
So we
Probably
leave
like-
those out.
6 inches on like each side, and then you just tie.
Once they're out, you'll have somebody holding pressure like,
Yep,
Once the tubes are out, you
so we
yep.
pull them straight out. They're still holding pressure, so any third spacing fluid, any blood or whatever is not gonna start pouring all over. And then we have those two ends and then
Yeah.
all we're doing is tying,
Mhm.
tie.
tie,
Yep.
tie. Until
And
you
then
have,
you leave like an inch out,
right.
so they can clip them.
Right. Have them perform practice breaths. So your other nurse, like I said, is gonna hold pressure, take a deep breath and hold it. And then remove them, and you're gonna wanna remove them pretty much. Grab both of them with both of your hands and pull extremely fast and extremely hard. And as we were just demonstrating that you guys did not see, tying the suture, so all you're doing is tying knots, that's all you're doing. And then tell the patient it's okay to breathe. Keep the dressing on there, and then they should feel tremendous afterwards.
Yay. What's our next one? I'll let you try.
You want the hemodynamics?
Yeah.
Okay. Bear with us while we change screens here.
Oh, yeah,
It's really small.
yeah.
Keep going. I'll talk to Jen. Or, I don't know, cardiology wise. Talk to Erica and see, but either having Jen Fox or Jen Fox. For cardiology, do like a pacemaker class.
Mhm.
Okay, sorry, I only have the handouts on this. I don't have the actual slides, so this is a little small. And it's not loading very well.
That's glitchy. See if I zoom in a couple more times.
That's better.
It's
Just
not-
in
it doesn't like.
just-
okay,
There we go. Okay.
That's better.
Have a bigger list.
Mhm. You get it,
Words he lives by.
right?
Should get the Honka virus.
All right, squad. Let's see here. Where do we want to start?
Is everybody here familiar with, do they feel comfortable with arterial lines, like transducing them, leveling them. Is there anybody that does not, anybody that wants to go over it again? Patient positioning, I think we get. Sure we all feel comfortable with it, but if we want to go over it again, that's completely fine.
This all talks a lot about how to set up an A line. So if you're not familiar or have a question, speak now. But I
When
think
you
all of us know how to do that.
level and zero any line, they should be flat.
Correct.
Ideally, yes.
If they
So in there,
If
like
they can.
the phlebostatic access. And obviously where that transducer is, no matter if it's a Swan or a CBP or an arterial line, the placement matters where it is. If it's too high on the patient, your blood pressure is going to be lower. If it's too low, your blood pressure is going to be higher.
What's right here, Joey?
I would go for dampened.
So optimally dampened system. So what you're gonna see is what you see on the screen there. You're gonna see a vertical upstroke. And it's gonna start to come down. You're gonna have where your aortic valve closes, which is gonna be your little notch there. And then it goes down. So anytime we come on to shift, if we have an arterial line, like I said, if we have a CVP, if we have any pressure line, Swan, we want to do a square wave test on that. And that square wave test is going to pretty much tell us how reliable it is. So if you go to, so that one there, so the first one there, as you can see, go back to the first one real quick. Where the square notches, we're going to pull our plunger, and that's what we want to see afterwards. So we want less than 3 rapid, we want less than 3 rapid auscultations afterwards. So that's how it should look. We have our square wave, it comes down, and then it goes right back into our waveform. We scroll down to the next one. You're gonna have over dampened. So we're gonna do our square wave test, and then it's just kind of flat. So think over dampened as like, almost like what a CVP looks like, or what it's supposed to look like. It's just kind of like a little bit of a mound. As opposed to the next one,
Ah,
right here, under dampened. So I always tell people, think of under dampened as like a needle under a haystack. A needle is very pointy, as we all know. And if you look at the A-line waveform there, it's very pointy at the top. So things to check for when this happens, I always start back at the bag and check if there's any fluid in the actual bag. Is it pumped up enough? A lot of times these lines will go dry and people just say, oh, well, it's not drawing back, or it's just an unreliable waveform, and then don't try to troubleshoot it. So from the bag, check, make sure you have fluid, make sure it's pumped up. And then start to work down, see if you see any air bubbles. Is the line kinked? Is the roller clamp, is it shut? One thing that I will do is I will hook up a like 10 cc syringe closest to the patient, and I will turn it off to the patient. So the stopcock towards the patient. And then I will pull the plunger and flush any fluid or any bubbles or anything like that into my 10 cc syringe until it fills up. A lot of times that will fix it. But a lot of times it's actually the patient and how they're moving. If they're moving their wrist more, do we need a splint on there? And sometimes it's who actually placed the line. Is it up against the artery? You know, is it in place? I've had them people, say, well, we didn't pull it because we want to wait for CV, and then I undo it and the line's not even physically in the patient anymore.
Or where it inserts is kinked.
Right. And that happens a lot also. Sometimes you have to just pull back on it. But obviously we know how valuable they are and we don't have to stick our patients. So the more that you can troubleshoot it and try and figure it out, it's better. If for some reason we're having blood pressure problems with these patients and we can't get this A line to draw back, we can also, ask AIP, and they're not busy, like, hey, can you rethread this? Can you check and see what the issue is? Because if we have it, great. If we don't, then, we're having to stick these patients or it's a benefit to us.
I'm just going through a lot of this stuff. We should all know. Kind of talked about this, the complications of an A line. They can thrombose or clot, or you can have arterial spasms. Again, both of them, just if the patient can, see if they can have the A line out.
And when we're doing, like Amanda said, when we're doing our assessment with these, look at their fingers. Sometimes they're black and blue and, we may have an issue where there is a clot in there and that's something that we obviously want to catch.
Mm-hmm.
Generally, the CV likes to keep their arterial lines in, and even if it's a flat line and you feel stupid, like keep it until they say to pull it. Sometimes they will go in there and they will rethread it if they want it. But just let them have the say on whether it needs to be removed or not, especially if they're on inotropes or pressors or anything like that.
Obviously, you guys all know how to take out an A line. Clip the sutures, deflate the bag, hold and maintain pressure for at least 5 minutes or until the bleeding stopped. And then place a pressure dressing on it. I always tell the patient to keep an eye on it to say, if you see any blood start to come through, or if you notice that your hand is feeling kind of warm and wet, please call me, because that's the problem. Hemodynamics.
I think the biggest thing that people have questions on is swans or PA catheters,
Mhm.
because we go through, I mean, if you take hearts or you get a lot of these patients, then you're familiar with it because they all have it. But, they kind of come and go on the units depending on the patients that we have. So you have 3 ports on these, as you guys all know. You have your right atrium port, your proximal port, that's gonna be your blue port. We can measure our CVPs off of there. This port, you can use this port for anything. You can give electrolytes through it, you can give fluids through it, you can give antibiotics through it, you can push those medications through it. You can put pressors through it if you want. General rule of thumb that we use is all of our pressors, inotropes, everything. Don't leave.
She's
I'm
gone.
back, Amanda. Is we put all of our pressors, inotropes into the white port. When they come back, they have a manifold with everything into it. But nothing says that, once that they're off inotropes, off pressors, that we can't push we can push anything we want through the white port also. The reason why we choose the white port is the white port is a little bit further. So when going in through the subclavian, generally you should hit the right atrium when you're at 30 centimeters. And that will be where your blue port is. Your white port generally is at 31 centimeters, so it's closer to the ventricle. So kind of the thinking is that you're getting that medication through the heart 1 centimeter faster, I guess. So CVPs, so CVP, once again, is just a number. And it can tell us a lot. It can be reliable, but it can also be unreliable. So we use it as a preload measure of the right side of the heart. It's technically not a fluid status, it's a pressure status. Normal is 2 to 6. CV wise, they like to keep their CVP before they give fluids and diuretics, they like to know what the CVP is. Generally, 10 is their rule of thumb. When they drop under 10, they like to give fluid. When it starts, between 10 and 15, they're okay. They may be thinking diuretics. When it's 15 or above, they're generally initiating diuretics on this patient, depending on how they look. Now, sometimes that CVP is, we'll say 20, and we would think right away, like, okay, we need to give Lasix, we need to give Bumex, but we also need to look at what our cardiac output is, what our urine measurement is. If, we're having little to no urine, we need to look at, is there an issue with the right side of the heart? And if there was in the case an issue with the right side of the heart, we're looking at giving medications such as milrinone or dobutamine. It all depends on who the surgeon is. Dr. Beckett likes milrinone over dobutamine. She is generally the only one that chooses milrinone over dobutamine in cases like that. Everybody else is pretty much dobutamine, especially if they have a low EF. So say their EF is like 15 to 20 when they come out, dobutamine is generally their choice. Years ago, they liked dopamine. Now they've kind of gone away from that. Yeah. So the venous infusion port is the white port. The VIP port, because that's where we put all of our pressors in, as I was just saying, so exits the RA at 31 centimeters, so that's where your white port is. And as I was saying, we can infuse anything through there, but rule of thumb when they come back from surgery, hey, Wilson. That's where all of our pressors are going to go. So the distal port is only used for one thing, and that is for mixed venuses. We can't infuse anything through there. If you do, you potentially are going to kill the patient. So this is your yellow port. You're going to see just like an arterial line, instead of the aortic valve closing, this is going to be your pulmonic valve closing. You'll see your dicrotic notch, which is your little kick up there. Like I said, the only thing that we draw through this is a mixed venous. So if we ever have issues with the PA port, so the yellow port, like we just had one a couple weeks ago, and we need a mixed venous, generally we will draw it from the blue port. If we cannot draw it from the yellow port, your reading will be slightly off because you're not getting that mixed oxygenation that you would get in the pulmonary artery. So it can be a little bit less. Once we draw from the blue port, we need to pass on to the next nurse, to AIP, to CV surgery when they round. It's not something we need to call them about. And just notify them that the PA port is no longer drawing, that we need to draw from the blue port. And then all of our mixed venuses from there on are going to be from the blue port, unless we can get that yellow port, working again. Normal PA pressures, we say, are 1/4 over a dime, so 25 over 10. That is for a normal person that's not having really any of these issues. So if you're seeing a patient that is 25 over 10 after open heart surgery, most of the time, these patients are going to be pretty dry and they're going to need fluid or they're gonna remove the line and, advance the patient. The balloon port that we've all seen when they come back from surgery, I will say this, it's usually opened and it's pulled back. And the downfall of this is if we turn our patients, we can inflate that balloon and wedge that balloon and potentially cause an ischemic event. Generally, these patients will complain of chest pain, usually crushing. That's one thing that we need to look at. We need to look at your patient, look at your waveform, and look at that syringe. But 100% of the time when they come back, even if you're helping somebody recover, look at that balloon, make sure that that syringe is closed and the syringe is not pulled back, because it will cause issues. So wedge pressure, generally, we don't do it a lot. We don't do it nearly enough. There's generally only 3 AIP physicians that will wedge for you. We cannot do it. If a doctor's at bedside, then they need to do it. But this is going to tell you pretty much your preload on the left side of your heart. As a rule of thumb, generally take your PA diastolic and -5, and that should be where your wedge pressure is at. Yeah, anytime that we advance that catheter, a physician has to do it. In an emergent situation, we can pull back on it. So if that line moves, our measurement is different and we start seeing what looks like VTAC, most likely it is VTAC because that line is irritating the right ventricle. So you'll see that rhythm on there, it'll alarm. And then we just need to pull that back and out of the RV. But a physician has to advance that catheter if we need to. Insertion wise, obviously this is done by CV in the OR. If we're doing it at bedside with one of our intensivists on any patient, generally they're pretty self-sufficient on the 3 that will actually put in a swan. And all we're there for, honestly, is assistance and to give them flushes if need be. They will have us look at the monitor, let them know what the tracings are. So once they get into the right atrium, you'll see a CVP waveform. As they advance it into the RV, once we start seeing that VTAC waveform, that's when they need to inflate their balloon and push it through. So we're there to pretty much do flushes and look at the monitor. Best practices. So these patients should be getting an X-ray when they have this in. They should be getting an X-ray when they have chest tubes in. I don't know, do we have a? If nobody has seen it on an X-ray, just ask one of the CV nurses to look. I'm sure you guys have all seen what a swan looks like in there. But it should come down. It should loop pretty much, it should look like a U on the spine and then come up and physically be at midline or just past the spine. That's a really awful analogy right there. That's really, yeah. I can see it, I just can't really explain it. But you'll be able to see it on most of the time, I will say. You'll be able to see it. If you ever have any issues, generally we don't have these issues with CV swans. It's mainly cardiology swans because cardiology swans, for some reason, do not lock. I don't know why they don't lock, but they don't. But the CV ones have 2 locks on them, so we generally don't have problems with them coming back or migrating further in. If your waveform is bad and you think you need a chest X-ray, order a chest X-ray and just notify AIP that my line is moved or there's an issue with it, because sometimes they will kink. They do hold a lot of slack inside the patient, so they can move that way.
The thick marks are 50 centimeters and the fin marks are 10. So you typically count backwards and find your, thickest line and then use the rest of the lines to kind of count forward to know placement. It's important to check anytime you move the patient, anytime they go for any sort of procedure, anytime they get in and out of bed, to check a placement, and if this one has moved to get a chest x-ray, notify AIP. There was one time I was in report and the nurse I was getting signed up from had said to me, oh, when I came in, this one was at 55 and now it's at 44. I was like, oh, did you tell anybody? No.
Okay.
That's what not to do. So if you notice it moved, please tell somebody so they can have it fixed. Cause like he said, it could be an emergent event where they go into some sort of dangerous arrhythmia.
We're supposed to be measuring at the hub thing and not at the set.
Correct.
Correct.
That was.
Correct. Excuse me. We just talked about this where if you have a wedge waveform, it can kind of look like a CVP waveform, but a little bit more dampened. And this kind of happens if your swan is kind of wedged in too far. You obviously want to make sure the balloon is deflated, like what Joe was just talking about. See if your swan has changed. See if your patient can kind of move around a little bit if they can, to see if it's just kind of a positional thing or what have you. And then you want to notify a provider. And you never want to flush these lines if you suspect that they are wedged, as that can cause a lot of damage.
Elaine, how's your coffee? Did you get it made?
She's
Coffee didn't
making
work.
She's
me
sleeping-
some,
she's
yes.
Sleeping right now.
Yes. Obviously, we all know the complications of having a PA catheter. We just kind of touched on all of them. With insertion, can be very possible that they can get a pneumo. Obviously, any sort of foreign object in the body is a higher risk of infection. Ventricular arrhythmias, if they kind of migrate to not the proper place, if they move in too far, they can cause pulmonary artery rupture or a perf, and the balloon can also perf if it stays inflated for too long by mistake. Excuse me.
You need coffee?
I need a nap. Cardiac output, we're really fortunate, and most of the time we have the continuous cardiac output swans that we use the hemisphere for. On the off chance that we get a manual swan, those are usually from cardiology. You typically won't see the one like that on a post-op open heart. But we obtain those by flushing the line with the setup 3 times, and then it'll kind of take the average for you and flow into the chart. If you are not sure on how to do that, please see your chart nurse or a CB nurse.
There's also a nice video of Amanda doing it on Teams.
Yes, from many moons ago.
Yeah.
Talks about how it gets it continuously. We don't have to worry about that. So what do all these numbers mean, right? We get all these numbers, and what do they mean? So in case you want to get even more confused, here's all of the numbers that we do get, and the important ones. So we're obviously going to get a CVP, like Joe already talked about, from the blue port. Your PA, systolic, diastolic, and mean are from the yellow port. Your wedge, we don't wedge, but you can kind of have a good idea on what your wedge would be based on your Diastolic on the continuous ones, you get a core temp, which is an important piece of information to have. And then you will get a mixed venous on our continuous hemispheres as well. The numbers on the right-hand side are numbers that are calculated for you. You don't have to do any math or anything to obtain them, which is super nice. And lots of times they'll flow over into your charting after you plug in the rest of the values, and Epic will kind of calculate them for you. And they're helpful numbers to have to kind of paint the clinical picture on if your patient's wet or dry, because that's always the question you're trying to ask. Do they have enough volume, or do they not have enough squeeze, or are they dry? And those numbers can kind of help paint a clearer image for you on kind of what is working for them and what's not. So your cardiac output isn't just some number that pops up on a screen when we press start. It is a calculated equation that is heart rate times stroke volume, which again is why it's so important to be mindful of what your stroke volume is, which can be pulled from the Epic flow sheets. Epic will calculate that for you once you place your CVP in and flow all your vitals and stuff in. It'll calculate that for you, but your cardiac output, which is your liters per minute, is your heart rate times your stroke volume, which is your milliliters per beat that is being pumped out. So what affects your stroke volume? But first, cardiac output can be changed by numerous things, which can all affect your heart rate, which is tachycardia, bradycardia, or rhythm changes. So when your patient is going into AFib, you'll notice if they still have a swan and are on the hemisphere, you'll probably notice that they will drop their cardiac index, because you are losing that squeeze that you had prior in your atrial kick. So your preload stretches the muscle at, I'm sorry, I think I just had a stroke. Preload, talking about Starling's law. It's the force that stretches the muscle fibers at rest. The higher the stretch, the greater the preload is. It's all volume and stretch dependent. Your CVP kind of tells you a really good image on what your preload is. Your normal is from 2 to 6. If you wanted to kind of know the preload on your left side, which is kind of how your volume is being measured on the left side, kind of what Joe talked about. That's where you check your pulmonary wedge pressure. Is that the last one?
No, it should be,
Let me zoom out. Give it a second.
be 46.
This thing is having a stroke as well.
I got your water.
Nope, that's just pee.
So, as Amanda was saying, so preload, when we think of preload, we think of the right side of the heart, because that's generally what we're measuring most of the time, since we don't wedge a lot. So we look at our causes. So if it's too high, say our CVP is 20, first thing that we think of is that we've got increased fluid volume. But we can also have peripheral constriction. So if we're in shock, stuff like that, where we're completely clamped down, and the fluid can't move from the right side of the heart to the left side of the heart, that can also increase your preload, as can, as Amanda was saying earlier, if somebody who's in like cardiac tamponade, where this is not a pump problem, but it's a problem of all of that fluid, blood surrounding the heart, not allowing it to contract. Your CVP is going to be raised because we can't move that fluid from right to left. So intervention wise, first thing we think of is diuretics, either Lasix or Bumex, sometimes a Lasix drip, sometimes a Bumex drip. Each physician is different. Beckett likes to use Lasix drips instead of Bumex. But if you notice that Lasix is not working, then we need to suggest to them, maybe we need to switch this off to Bumex. So on the other side of the spectrum, too low, things that we're thinking of is this patient dry? Are they hypovolemic? Are they completely dilated? Is this full-blown sepsis where we're so far into septic shock that now we're in vasodilatory shock where everything is wide open? And then arrhythmias, as Amanda was saying, if you're in that's
I'm next. I'm next.
in AFib where we're not moving that fluid and our cardiac index is dropping because you don't have that squeeze. For somebody who is in SVT, same exact thing. You have that squeeze, but it's so fast that pushing it from your atrium to your ventricle is just in like short little spurts. So what do? Volume, crystalloids, colloids, sometimes blood. These open heart patients love blood. They love albumin. LR right off the bat, they generally will like, especially if it's a valve. But once again, that fluid just kind of third spaces and these patients start to get puffy. So your afterload is the pressure that the ventricle has to work, whether it's the right ventricle or the left ventricle, pressure that it has to work to get past those valves. On the right side of the heart, so your RV is pushing against your pulmonary, will be your pulmonary vascular resistance, so the in your lungs. And then your LV would be your SVR, which is the one that we pay most attention to.
Mhm.
Normal is between 800 and 1200. If it's over, 1200 or above, that means they're clamped down. If it's below 800, then usually they're vasoplegic and they're wide open. So we just need to determine what we need to give versus, is it diuretics or is it
Inotropes.
fluid or inotropes, depending on if the fluid's moving from right to left.
Mhm.
Afterload, so things that will cause this. So hypertension, vasoconstriction, hypothermia, pain and anxiety, which is honestly a lot of it, and that's why they are very adamant, are very pro to giving these patients pain control. If they're hypovolemic, so the compensatory measure obviously is that we're going to, our body's natural thing is to clamp down and to ramp up the heart rate. Interventions, so treat the cause, it's a lot of times it's pain. But sometimes it's that, fluid's not moving from the right side to the left side and we need inotropes. We may need vasodilators for this. Start warming the patients, which by the time post-op wise, by the time we get them on post-op day 1, they should be plenty warm. If we need to give them volume, if it's too low, as I said before, are they vasodilated? Are they in full-blown sepsis? Do they have a fever? Are they in multi-organ dysfunction? Are they having an allergic reaction? And then interventions, give fluid and start giving them pressors, which generally is Levo. So as Amanda said, so preload, afterload, contractility, those are the three numbers that we base everything off of. And if you can find out what your preload is, what your afterload is, and what your contractility is, you can generally solve any of these problems. So we use our cardiac index and we use our stroke volume. So our normal stroke volume is going to be anywhere between 60 and 100. A lot of these patients, are generally lower than that, but that is the general rule of thumb. Cardiac index, we want 2 and above. That's our general rule of thumb.
He does like the thumb.
Did I say it? How many times? I said that? A lot? All right.
He's talking about my thumb.
Rule of Amanda's.
This thing is having a stroke too. Baseball.
50-50.
Huckleberry.
Ma'am, can you read this cardiac menu? Probably one of the greatest moments
Mhm.
in our history, I would say.
Okay, there.
Oh, I wonder how he's doing. Oh, it made me cry.
Right.
That's the worst. So contractility issues. If it's too low, are they having an MI? Do they have cardiomyopathy? Are these patients hypoxic or are they acidotic? If you have any questions, draw an ABG, draw a mixed venous and see where they're at. Are they having any electrolyte imbalances? Mainly potassium and magnesium. And then what agents did we give them? Are they on Precedex? Did we give them beta blockers? Stuff like that. Interventions, what we're going to do, give them inotropes, and then optimize their preload and their afterload. So whether we need to give things that will tighten them up or loosen them up. 2 high causes, central nervous system stimulation, and then drugs such as epi, levo will sometimes do it. Dobutamine is known for it. Even dobutamine can raise their heart rate. And then interventions, treat what you think that it is, give them beta blockers. A lot of things that you guys already do on your patients. There should be one more.
Nope.
No 51?
Oh, yeah. I was just on that one.
Oh.
Okay. There you go.
Other factors, acid-base imbalance, as we said, draw an ABG, check their electrolytes, draw labs. Yeah, we just talked about all that.
Mhm.
Thanks for skipping that one. After that, so,
Thanks.
5 minutes later.
Mhm. And we're back.
And we're back. All right, so the mixed venous themselves, I know you guys have all drawn them off of your swans. Is there anybody that doesn't understand what we're looking for and what our numbers actually mean? Don't be shy. I'll give you a brief analysis here. How
Oh,
about
thank
that?
God.
Huh?
Yes, thank you.
What is
Nothing.
this?
Well, Lane wants to know.
What is Elaine?
No.
I'm having a headache, too much
I'm just
info.
being a turd.
You said you were gonna explain it. Oh, thank God.
Oh,
Elaine is done making her coffee and
Thank
she's
God.
ready.
Elaine's like, I just woke up.
I'm listening. I'm having a headache because my brain cannot take all the info. Just kidding.
Elaine, I think you've been doing this longer than all 3 of us combined in here. So I think you're good. All right, so mixed venous. So what we're looking for when we draw out of that yellow port. So this is going to tell us this is much better than our output. This is much better than our index. This is going to tell you how well your body is oxygenating, how well it's using that oxygen,
Perfusion.
perfusion. So our normal is 60 to 80. And anything generally below that, we need to look at what is causing that. And we will address that.
Great.
So it says 60 to 75, but 60 to 80 is generally
Mhm.
what is the rule of thumb. Which means 25 per, generally 20 to 25% of that is extracted into the tissues. So if it's too low, we need to look at what's causing that. Is this somebody who's going into cardiogenic shock? And they're just they can't use that oxygenation? Or are they pulling off too much of that oxygenation? So those tissues are starving. And so two main causes are cardiogenic shock and hypovolemic shock. So hypovolemic shock, because if we don't have that volume to move those hemoglobin, then we're going to be on the lower side. So think of somebody who is extremely dry, somebody who's had mass trauma and they're bleeding out. And then we look at if it's too high, we're looking at the tissues aren't using that oxygenation. And what you're using instead is lactic acid. So this will be somebody that is septic. So if you have somebody that came back from surgery and a couple days later, is just looking ill, they're having fevers, you're having blood pressure issues, you draw a mixed venous, and now their mixed venous is, we'll say 90. That's somebody we want to look at, is this patient going septic? And we're switching over to the Krebs cycle. Is
You
that
got
what
it.
I'd like to say?
Yes,
And
the crabs.
Mr. Krabs.
we're using lactic acid versus oxygenation, or versus
Is there a
Oxygen.
rule of thumb?
what? The rule of
I
Amanda's thumb is that when these patients come back, and it could be a regular surgical patient or whatever that has a swan or something like that. And when they come back from surgery, they're coming back on high FiO2. So they're coming back at 100%.
Mhm.
So you can expect that their mixed venous is not going to be accurate at all. So generally what I will do is kind of write that number off because we're giving them 100% oxygen. So obviously it's going to be skewed. Now, when we knock them down to like 50% or we extubate them, then I will draw another mixed venous to get a true calculation of where we're at because we're not getting that high influx of oxygenation. Our hemispheres are continuous.
This thing is so stupid.
You're hurting my computer's feelings.
They still sell Dells.
Whatever the hospital gave me.
That explains it. The best money can buy.
Something's operating on CS1. 55.
Come on. Let's get with the times. All right.
So conditions that increase your oxygen demand. So anxiety, nursing assessments, interventions, stuff like that, that can obviously hurt it. Burns, shivering. So when they come back from surgery, hyperthermia, visitors. That's why we should have restrictions. Skeletal injuries, chest trauma, head injuries. That just kind of gives you the percentage. And then things that can decrease. So things that work against us when they're coming back from surgery. Obviously, they come back, they're on propofol, so that's going to skew it. And then hypothermia is a huge one. We need to start warming these patients. Causes of increased pulmonary artery pressure. So could be the lining of the PA, so nothing that we have any say about. This is just the patient themselves. Hypoxia, pulmonary edema, pulmonary vascular congestion, patients that are in ARDS, or left heart systolic dysfunction. So pretty much know 60 to 80 is your normal. And there's other factors that can increase it. There's other factors that can lower it. Look at your patient and determine, a lot of times if it's low, they just need fluid. But that's why when I was saying earlier that after we stop an intervention such as an inotrope, dobutamine, milrinone, if we stop pacing this patient 100%, at 80 beats per minute, they regain their normal rhythm back and now they're beating at 60, then maybe these patients need a faster heart rate, or maybe they need more volume. Draw labs, maybe their hemoglobin is low. Do they need blood? Stuff like that. So it's not fail proof, but it gives you 99.9% of the answers that you need to try and figure something out. And I've seen a lot where these interventions are stopped. I come in and I'm looking at my hemisphere that hasn't been recalculated in, 16 hours. And the patient just doesn't look great. You draw a mixed venous and lo and behold, it's now 40. And they're going back into cardiogenic shock. So just something to be aware of.
It's also important to be mindful of what you're charting for your mixed. If you come in and when you did your first assessment, you're charting a mixed of 60, and before you leave for your shift, at 4 o'clock, your mixed is 40. That requires
What is this?
4. That requires assessment and intervention. So you can't be just charting a mix that's wrong for your shift without doing something. Now that's drawing another mix to recalibrate it, to kind of check on your evaluation. If that is truly that low, then you need to notify your provider and start some other interventions that we've kind of already touched on. But I think lots of people don't realize what they are actually like charting, and that you need to be mindful. It's the same thing as charting a hypotensive pressure for the rest of the night and not doing anything about it. And that's the rule of my thumb.
I remember when you're setting up your hemisphere to get your numbers, you need a mixed venous, you need a hemoglobin, you need a hematocrit, and you need a mixed venous oxygenation number to get that, because there's been times where I've walked in and it's just not set up and they can't figure out why. Well, that's because why.
And you don't need an order to do that. You can put the order in under anybody. Part of the protocol of having a hemisphere. You don't need to call the provider to get a mix. You can just get one.
But just remember to do one at least every morning recalibrated.
So next, kind of goes into a lot of the different drips and how they play a part on the body and how they work. So I'm sure everyone remembers from school the difference between your autonomic and your sympathetic nervous system. Kind of talks about your fight or flight and your rest and digest. And when you understand kind of how these two systems work, you kind of understand how the different medications work. So there's different receptors that each of the medications use to work, and that's why they're all different and why they're not interchangeable. Hold please. Kelly's computer is still on dial-up, so I'm not gonna go super in depth to all the medications and the pathophys of them all, but here's a lot of the medications that you can see on a post-op heart. It's not as common to see them all on post-op day one. You'll more than likely just see one of these, if any. But it's important to be aware of them and how all of them work. So you've got your Does that sound ring a bell for anybody?
Mail.
Right. And make sure you're off the phone too. Oh,
There's
God.
your free minutes in the mail, like
Yes.
7,500 minutes.
Oh my gosh, I forgot.
All right, so alpha 1 is pretty much just straight vasoconstriction. When you think of alpha 1, you think of phenylephrine. Really, it doesn't have anything to do with heart rate or contractility. Beta 1 has a lot to it's located in the heart and the kidneys. Oh, excuse me. Sorry, I'm just reading all the things that this said. So it helps to increases the firing of the SA node, the AV node, and the ventricular muscle, leading to increased heart rate and contractility. So those are the two differences between them. One is just straight vasoconstriction, and one has a lot to do with increasing the heart rate and contractility. Beta 2, located in smooth muscles, but also GI tract, bladder, uterus, and seminal tract. It causes dilation and increased perfusion to the muscle cells. That one works. And we already touched on the parasympathetic response. So here's the different medications and kind of how they work. So when I was talking earlier about beta 1, when you think of that, you should think of norepinephrine. Works by adding squeeze and increasing your heart rate. That's why if your patient is super tachycardic, is an AFib with RVR, norepinephrine isn't the best drug for that patient, because you're just going to make them more tachycardic normally. It increases myocardial contractility, which therefore increases afterload. And it's the first line pressor for sepsis. Like I was talking about before, phenylephrine is mostly acting on straight alpha, so that's just straight vasoconstriction. You're not going to get any of the cardiac benefits that you'll get from like dobutamine and dopamine levo, because you're just getting vasoconstriction, which is the benefit if your patient's super tachycardic. Epi, all of us know Epi, it's a code drug. You will very rarely see this on a post-op day 1 patient unless they're really not doing well at all. They typically try and stay away from Epi on the hearts because it causes an increase in lactic acid and increase in myocardial oxygen demand. So if they're on this, they're usually on this because other drugs aren't working. It's not a first line choice. Vaso, we'll see this because it's anti-diuretic hormone. Again, they're not typically just on this. They're on this if other medications didn't work. You'll more or less see this on a patient who is a GI bleed or a second line pressor for sepsis or something like that. Telling you this computer. Back up to the pressors. Dopamine. So acts on both alpha, beta, and the dopaminergic receptors. Depending on the dose of dopamine, it can actually act differently on the body and the different receptors. So there's research that shows that low dose dopamine can stimulate renal perfusion. And then if you're at a medium dose, like 4 to 10 mics, you're acting more on your beta 1, which is increasing your heart rate and your contractility. And then if you're on a super high dose, you're acting on multiple different receptors, and the patients can get super tachycardic and sick. So again, on a post-op day 1 heart, you're probably not going to see anybody on that high of a dose. So you're typically going to see like a dose of 1 to 4 mics to increase contractility and increase squeeze. Angie 2, again, you will not see on a post-op day 1 heart, but it is for last resort if all these other meds don't work in shock and vasoplegia. Inotropes, so dobutamine helps to stimulate beta 1 and increases contractility, so that squeeze that we keep talking about, and increases beta 2, which kind of causes a vasodilation effect on the afterload side. So when we were talking before, we were talking about afterload being how hard the heart kind of has to pump to get the blood out to the rest of the body. So if your SVR or your afterload is super clamped down because your patients had a history of heart failure or super low EF, dobutamine's a great drug to kind of help offload that afterload and dilate out that left side while adding squeeze as well.
So if your SVR is high,
Yes.
it's got more pressure to work against. So
Yes.
dilate it with the butamine.
Exactly. Exactly. And that's kind of how you know too, if your patient's on maybe like too high of a dose, or if it's working too well, you'll see your SVR get kind of super low. And milrinone kind of helps to dilate out on the pulmonary side. So if you're trying to move blood from the right side over the pulmonary side into your PAs, it's a pulmonary vasodilator and also helps with contractility and squeeze. Daddy's home.
You get that as money. Plug it in.
Joe and I can't be trusted. Nitro, all of us kind of know how that works. It's a venous vasodilator. You get any higher than, like a dose of 40, 50, all you're going to do is give your patient a headache. It can help to dilate out if you're having some issues with SVR, but again, there's other drugs that kind of typically we use instead of that. Nipride, it's kind of an old drug. We don't use a lot of anymore because it can cause cyanide toxicity. But it helps to control blood pressure and decreases afterload and myocardial oxygen consumption. Cardine is the drug we will typically see for treatment of hypertension. Now, by post-op day 1, we typically wouldn't be starting anybody on a drip like this unless they're like severely uncontrolled. These are the times you would be using like your hydralazine or something else rather than starting them on a continuous infusion unless otherwise directed by the provider. Come on. Okay, so this screen right here, which everybody can see, right? It's just super small. So you can pull up this image pretty much anywhere. I really like it because it kind of is a crash course. Right. It kind of is a crash course on how the different medications work, the normal dosages that we use, which receptors they act on, how they affect your heart rate, how they affect your SVR. So if you're like, what were they talking about with this drug causes an increase in this and a decrease in this little handout I usually give to all my orientees because it is super helpful for like a quick guide. And when I first started taking hearts like 7 or 8 years ago, I kept this on me because it was helpful to kind of keep everything straight and how, if I started this medication, how is that going to change all my hemodynamics? And then we're not going to go through these case studies because that is more of the post-op immediate period. And I think that's it too. Does anybody have any questions about anything we just talked about? Any questions about overflow hearts, the post-op day 1 hearts, the orders, any questions about any of that kind of stuff? Elaine,
Can I have-
how was the coffee?
Good, I finished
Okay, good.
my toasted bread and my coffee. Can I have a copy of that medication list?
Yes, I will print some off and I will leave it in the binder of the CV binder in the education room.
Oh, okay, thanks.
I will print some off and put it in the front of it so that anybody who wants to have it can have access to it. It
Okay.
is a really helpful guide, I think. Any other questions? All right, you guys know Joe and I are here for any questions or concerns that you guys have. Anybody who takes heart should be able to answer questions on kind of how to troubleshoot things, what the different numbers mean, what the different medications mean, as well as your charge nurse too. If you have questions, feel free to email either Joe, Kelly, or myself, and we can help you work through some things. If you want different scenarios to kind of talk through, feel free to reach out to us at any time and we'll be happy to do that.